Hey everybody, it's Friday once again. Welcome to the One City Studios of Tennessee Orthopedic Alliance. When it's Friday, that means the doctor is in, live with TOA, is in the house. Good to see you. Hope y'all are doing well. Again, thanks as always for tuning in. I hope these episodes are at least entertaining, if not informational for you. If you have any ideas for topics, please comment below and we'll try to get to them. I know Debbie Uchida, you asked for something about scoliosis, and we've talked about scoliosis. You might go back last spring when we talked to Snowden about scoliosis, but I think we're going to go back to scoliosis again at some point in the near future. We'll get Snowden back on, Dr. Snowden back on, and talk more about that because I think it's an interesting topic, particularly in the adult. It's a challenging field, so thanks for that. Good to hear from you, by the way. It's been a long time since we've seen one another. Today is Friday. It's almost Father's Day. I'm not a father, but for you people who are fathers, thank you. Celebrate with your families. It's also, guess what? Summer coming up Sunday. Yikes. It's hot already, so be out there, drink lots of water. Don't get hurt, but if you do get hurt, guess what? TOA.com is the place to go. You can learn about anything we do. So our services, our people, our locations. You can go back to our vast video library in our media center on the website to see me or other people who've done videos to try to get you some information about musculoskeletal care, because injury, degeneration, wearing out is a part of life, and many times we can do a lot of things to try to help you improve your lifestyle and get you back going again, so don't let it linger. Come see us if you need us. TOA.com is the place to get all that information. Today, as you can see, I don't have a guest. I thought today our topic would be a follow-on to our Spine 101 episode that I did April 30th. And it's actually good to go back to that one because this one dovetails nicely with that one. That episode was about spine fusion in general. Today we're going to delve into a little bit more of the science of spine fusion, because this is something that there's a lot of words that get thrown around if you're talking about surgery for your spine and having a spine fusion that get a little confusing, and it's kind of interesting. It's also a big hot topic in bone surgery in general, because many of these same topics come about with certain types of bone fracture repair or bone corrective surgery. So I thought I'd delve into a little bit about the basic science of some of these things, some of the topics and terms, so that you can get a better idea of what we're talking about. So without further ado, we'll go to the topic. So recalling from our episode in April, bone fusion or bone healing is the same thing. When we fuse somebody's spine, we are trying to create an environment that your body thinks it's got a broken bone and basically says, oh, got a broken bone, grow bone here. I can't remember if I told you guys this last time, but there are only two tissues in your body that heal with its own tissue. When you cut your skin, or you cut your kidney, or you have your intestines pulled out and put back together, they heal with scar tissue, which is a normal tissue, but it's not the native tissue of that structure. The liver, if you cut your liver, the liver heals with itself. So if you cut your liver and it heals, it has functioning liver where that injury was. Bone is the same thing. Bone grows bone when it's been injured. And that we utilize that effect to our advantage when we're trying to do things to change the skeleton, and spine fusion is one of those things. So when a bone breaks, basically you've got an area around the injury where the defect in the bone is surrounded by blood and bone marrow. And that blood and bone marrow contains a lot of substances. There's bone fragments, there's calcium and other minerals from the bone that are part of that, essentially a bag of goo around that injury. There's proteins that are involved in promoting bone growth. These are called growth factors. There's blood cells and platelets and other blood-borne materials that create this kind of goopy mess that turns into almost like a jelly. That's the clot of the fracture, of the bleeding area, that then becomes a matrix for cells to grow. In bone healing, there's two types of cell behavior in general, bone cells. There is osteoblasts, which are cells, bone cells that grow more bone, and there are what are called osteoclasts, which are cells that kind of eat away bone. And in order to heal bone or create bone, you actually have to eat away some bone and build more bone. It's kind of a balance, okay? When those cells are really active, we start to see bone grow or change. There's another set of terms that goes along with this, with these cells and particles and things like that that are trying to be involved with bone growth. And those two terms are called osteoinductive and osteoconductive. So conductive means it basically allows bone cells to grow along it. Inductive means it promotes bone cells to grow along it. So they work together, and these various products that we're going to talk about, the biologics and the bone grafts, have varying degrees of osteoinductive properties, meaning promoting bone to grow, and osteoconductive properties, meaning showing where to grow the bone. And we'll talk about those because they have differences as far as how well bone grows. Remember, we're still in the spine fusion and in certain types of bone correction surgeries. What we are trying to do is fool the body into thinking that something bad has happened, a traumatic event has happened, bone has broken, and we need to grow bone. So our goal is we want solid bone in order to make things more rigid and put back together. That's what we're trying to do. So we've got osteoblasts, bone growing cells, osteoclasts, bone dissolving or eating away cells that work in combination. We've got osteoinductive, promoting bone growth, osteoconductive, showing where to grow the bone. We've got a couple other terms that are important with regard to bone graft, and that's basically where the graft comes from. We can get bone from your own body. So it's your bone, just like you had a broken bone, but we usually get it from some other place in your body and move it to where we're working. That's called autograft, A-U-T-O graft. So that's your own bone being put into a place, taking it from one place and putting it into another. There's also called allograft, which means bone from another human, but not yours. And there's a huge list of types of bone that can be taken from a dead person, a cadaver, a donor, which is a human, processed in various ways and used in various ways to reconstruct the body. In the spine, for spine fusion, there's really kind of two types of allograft that's used. One is crunched up bone, so it's particles of bone. It's kind of like the little particles of bone that are seen around a fracture. And we use those. Those are ground up bone. And then there's what we call structural bone, which is more solid, more rigid, more three-dimensional. And those are used to reconstruct bigger chunks of missing bone or areas that we're trying to span a bigger area, okay? And all of this has to do with the osteoblasts and osteoclasts, how they work to create bone, okay? So allograft bone, somebody else human, autograft bone, your own bone, and then the last one, which is kind of interesting, it doesn't really apply to orthopedics very often. However, I personally have experience with it. It's called xenograft, and that means bone from another animal, not a human. We don't use that much because human bone is the best for doing what we do in spine. However, personally, I had a tumor in my jaw. They removed part of my jaw and reconstructed my jaw about 10 years ago. And in addition to using my own bone from my hip, they used cow bone. And it turns out that at least in oral surgery, animal bone is almost as good as my own bone, human bone, because there's so much of a blood supply in the mouth that it really can't tell a difference. And so, interestingly, I have moo cow in my face, and it worked out pretty well. So we don't use that in the spine typically. We don't use that in the appendicular skeleton, the arms and legs and stuff typically. We use human bone. Now, all of the bone that we use, allograft bone, is processed. Some of it is deep frozen to maintain structure. Some of it is ground up, freeze-dried, which destroys all the cells and the soft tissue components to it and leaves behind just this calcium structure. And some of it is processed in between. There's material that we can process that gets rid of the mineral part, saves some of the protein part to try to help promote bone growth. Why would we want to process it? Well, the most important reason is, well, there's two. One is storage. We can use it and store it. So the freeze-dried stuff is dry, crumbly bone or dry, solid bone, and it can sit on a shelf. The frozen has to be in a deep freezer, but it maintains more integrity of the bone where it came from, meaning it's more like the original rather than man-processed. But the other big reason why we process bone is because bone, just like any other tissue from another person, can potentially transmit diseases, primarily virus-based diseases like hepatitis and HIV/AIDS. Now, fortunately, all of these tissues, when we get them, have been, the donor, the dead person, has been evaluated. They don't have these types of infectious diseases by testing. And then all of these processing techniques substantially or completely remove the soft tissues and the cellular part of things that can potentially transmit diseases. So even though it's theoretically possible to transmit disease with bone from a donor, it's extremely unlikely. And in fact, I think there's very few incidences where it's actually been documented that one of these types of infectious diseases has been transmitted to a recipient, okay? So the last thing about bone is what kind of bone is it? So in our bodies, we have what's called cortical bone, which is the hard, rigid bone that gives us structure. And then what's called cancellous bone, which is actually more of a spongy bone. If you look at it, it looks like a dish sponge. And the reason why cancellous bone and cortical bone are mixed up in your body is cortical bone is strong, but it's heavy. Cancellous bone is very light comparatively, a little bit flexible. And so, for example, the ends of your bones, the thigh bone, the shin bone, your arms and legs, the ends of the bones have a thin shell of cortical bone surrounding this spongy bone, the cancellous bone. The shafts, the mid portion of your thigh bone, shin bone, and arm bones, for example, are much more simply just the rigid cortical bone. That's the structural part of your bone. But we can use these in different ways with regard to bone grafting to try to help promote growth of bone, the osteoblast cells coming in and the osteoclast cells that dissolve the structure away to become living bone. The last thing in bone graft biologics is kind of the man-made types of materials. So bone is a bunch of different minerals. Hydroxyapatite and tricalcium phosphate are the two most important in our bone. We can actually make those in the lab or manufacture them. And so we can use that as well to augment the bone graft materials. And there's a variety of products out there of varying sorts to try to help improve the chance that we will get bone growing. So what we're trying to do with any of these products is promote bone growth, osteoinduction, and to tell bone where to grow, osteoconduction. Now, all of the products that we have, the calcium tricalcium phosphate, the hydroxyapatites, the ground up bone, the structural bone, those don't have much, if any, osteoinductive properties. Osteoinduction comes from living cells. It comes from the proteins in our body. So encouraging bone growth or promoting bone growth doesn't really happen with these structural or ground up products. They are conductive, meaning once the bone cells get there, they kind of see, oh, it looks like bone over here, I'll grow some more bone here, and it's kind of like bridging, and they think about this crumbled mess of panko breadcrumbs in your body, and little teeny cells jump from each panko breadcrumb to another and grow bone between them. And so that becomes more and more solid. So those ground up products, even the structural products, are not so much inductive, but they're conductive. They're trying to show, we're trying to use those products to fill the blanks so that we can tell the body grow bone here, okay? So that leads me to the biologic side of things. And this is really the more exciting field. Bone grafting has been around forever. Originally, we used to take all the bone from the person themselves. The problem with that is, and it's still probably the gold standard that we measure everything against as far as outcomes, as far as did it grow bone where we want it to in an appropriate manner. The problem with taking bone from the patient themselves is, number one, there's a limited supply of bone that we can get. We can only get it from certain locations, and there's not an unlimited supply of it. So if we need a big, long stretch of bone to show the body where to grow bone, we can't get that from the body itself. Secondly, it's oftentimes morbid to get that bone. Many times, or if people have had spine surgery primarily many years ago, we would take bone from the patient. Well, we'd have to do that through a separate incision at a separate body part, and that's actually very painful. And it increased the chance of infection, it increased the chance of pain, and many times actually people would have more trouble with their bone graft site than they would from the original operation site. And so we've always sought to try to find the materials, man-made or otherwise, to try to improve and achieve the level of fusion that we can get with the patient's own bone without the morbidity or trauma caused by obtaining that bone. And so a big field of interest is actually now reproducing or trying to reproduce the proteins that are part of your body's osteoinductive system. The proteins in your body, or growth factors, that help to stimulate bone cells, osteoblasts and osteoclasts, to work to create bone. And so many of these, the first one that really came out was a product called bone morphogenetic protein, big long word, BMP, and it's a profoundly powerful protein that is man-made. It mimics or essentially copies the body-made BMP, and the purpose of that is to really rev up the bone healing process. So we would use BMP in an area where we had lots of missing places in the spine, or we needed to really get a solid fusion as quickly as possible, and this is put in the wound around the area that we're trying to fuse in hopes that it will rev up your bone promotion and creation system to really make it solid. There are some other products out there, various different growth factors. It's a big industry. Problems with the BMPs and other biologics is they're very expensive, and there is some potential risk to them. Imagine if I have a system in my body that is designed to grow cells. If I rev up that system and make it really grow cells, sometimes the cell growth can have errors in it, mutations, and that can actually promote cancer formation, because that's what cancer is. Cancer is normal cells that have gone wacko and are no longer acting like they're supposed to. They're basically cells growing without any restraint. And so when somebody gets breast cancer, for example, it's breast cells growing out of control. And that's typically what cancer is in simple terms. And so it is theoretically possible, at least, that by using these growth factors and really magnifying their use and magnifying their action, we can potentially create bone cell tumors. There's a lot of science behind how much is enough, how much is too much, and that's a process that keeps on going. So we are careful with the BMPs and other proteins because they're super, super expensive, and there is some risk. So for example, if we have a patient we're taking out a tumor in their spine and we're fusing their spine together to make it more stable, we would not typically put BMP in that fusion construct for fear of promoting their cancer cells that are already there to go wildly crazy and increase in volume. We also are very cautious about using those types of materials in the children. The reason being is we have no idea what a life of those materials in your body does. The fortunate thing is kids typically fuse extremely quickly and extremely well. Their bone growing system is robust and healthy. As you start getting older, as you start becoming an adult, the bone growth system changes. And as we start harming our bodies with chemicals, with nicotine, with bad health, those systems decline, and many times augmenting those systems with these various biologic products in the middle-aged and older person is really what we need to do in order to get them fused. So lots of basic science, lots of terminology, people undergoing spine surgery, what are called osteotomies, which are corrective procedures for various parts like the wrist, the knee, and whatnot, may be talking about bone graft or autograft or allograft, these space-filling things to try to promote bone to grow. If you ever have a joint fused together, stopping the motion, you are using graft of some kind to help tell your body where to grow bone. So it's a lot of terminology. So to wind up, bone cells are important for bone growth. Osteoblasts grow bone, osteoclasts dissolve bone. So osteoblasts beat osteoclasts and you get bone growth. Allograft, autograft, and xenograft. Allograft is bone from another person. So donor bone, bone bank bone, cadaver bone, those are all similar terms. Autograft bone is from the patient themselves. If they have a small amount of need or local need, we can use autograft bone. We often use autograft bone and add to it some allograft bone to get enough volume to fill the space in spine. And then xenograft is not really applicable to the human in spine, certainly, but in other areas like oral surgery, it might be used. And that's bone coming from another type of animal, most commonly cow. Cancellous bone, cortical bone. Cancellous bone is the spongy bone that's kind of a space filler. Oh, by the way, the bone marrow, which is your blood cell producing organ in your body, sits inside the cancellous bone. So it's not just a spongy network of holes and cracks like Swiss cheese. All of those holes and cracks are filled with cells of your bone marrow that actually produce your red blood cells, which carry oxygen, your white blood cells, which fight off infection and invaders, and the platelets, which are the clotting cells, okay? So those, when people have, you may have heard people who've had to have a bone marrow biopsy if they have something like leukemia or lymphoma. And what they're doing is they're actually sampling the cancellous bone and the marrow inside it to see if there's an abnormality in the blood cell growing mechanism, okay? So cancellous bone is the spongy bone, adds lightness and a little bit of flexibility. Cortical bone is rigid, hard, structurally very sound, and we use both of those types of bone in musculoskeletal care. Going back, we can freeze dry it, we can freeze it, we can use fresh bone if we have to. We typically don't unless it's a big chunk of bone with, if somebody wants to reconstruct a leg or an arm where they need cartilage, where they need other soft tissues, you can use fresh. There's an increased chance of having an allergic reaction or a disease transmission with fresh as compared to freeze-dried. In spine, we almost always use freeze-dried, whether it's structural or crumbled up bone. And then the biologics, primarily trying to mimic the proteins that occur in the body. We take those proteins and generate them in a lab to create large volumes of those to then be used to try to promote bone to grow. So again, spine fusion is lots of science, a little bit of technique, and quite a bit of an art to get it right. What we're trying to accomplish with spine fusion is making something more solid or more rigid or more stable. And essentially what we're doing is we're fooling the body into thinking it has a broken bone, so all those systems can then go to that area and grow bone, because we're relying on the bone to make things more rigid. Again, going back to the April episode, the hardware, the screws and rods and things like that, are really only an internal splint. That's not the fusion. They're to hold things still so those bone cells can do the job. We used to joke when I was a resident that the osteoblasts don't like a big OJD, osteoblast jumping distance. They don't like a big distance between the next bone cell to create bone. They like lots of bone cells and particles close together. They also don't like movement. So if movements like this, the little cells can't grow the little bridging bone and it kind of constantly breaks. And so the hardware is there to make things more still so that those little osteoblasts can do their job and grow more bone. So I know I threw a lot at you. It's kind of a dry, boring topic, but it's actually kind of interesting. Very important technologies in this day and age. It's really allowed us, not only in spine, but in orthopedics, to really do many more things that at one point we never could do using both nature and man-made science. Okay, so that's it for today. We are not going to have a show next week. TOA is having TOA Day, and basically what we're going to be doing is, with all of our employees across all of our offices, we're essentially going to celebrate our employees. We're going to have games, we're going to have fun, we're going to have prizes, and it's really to help us celebrate our employees, thank our patients, really build up the morale that has really been declining from COVID and everything else. Our folks have worked above and beyond during this last year and a half, and we want to thank them a little bit. So we're not going to have any show next week. The following week is 4th of July weekend, so we're not going to be around. I'm going to be hanging in South Carolina where it's hot. But we'll be back in a few weeks. Good news is we've already got some people set up. Dr. Douglas is going to be talking about some hand and upper extremity things. We have Dr. Christian Anderson back. Not sure what he wants to talk about, but we talked to him a long time ago about PRP, this platelet-rich plasma, which is a type of a biologic to try to help with certain types of inflammation fighting and healing of soft tissues. So I look forward to talking to him. He's always an interesting guy. He's really a smart guy. So anyway, that's it for today. Go to TOA.com, learn about us, online appointment scheduling, go to the Media Center, learn about Dr. Rose in Hendersonville, learn about Dr. Barrett in Murfreesboro, learn about Dr. Williams in Cookeville, learn about Dr. McGehee in Franklin. Anyway, thanks again. Hope this has been helpful. Go out there, enjoy yourself, celebrate Father's Day, drink lots of water, go get vaccinated. We're getting to the end. Let's just all do it. And if you're so inclined. And go out there, live your best life. We'll see you in a couple weeks.